Let's take a look at some cross-sectional images of the kidneys in the adrenal glands. The required reading is from the 4th edition of the sectional anatomy textbook by Kelly and Peterson. Don't freak out because there's 100 pages listed here. In fact, there might even be 200 pages because almost all of the pages are images, and that's a lot easier to learn from than to have to read 200 pages of pure text. Over on the right, we have a list of all of the items that I'd like you to learn and to be able to identify on a cross-sectional CT scan of the abdomen and pelvis. This includes abdominal viscera as well as pelvic viscera and the retroperitoneal structures, including the kidneys that come from this talk. Take the PowerPoint out of presentation mode, double-click on this, and you should be able to download your list as a Word document. So it goes without saying that there has to be some boundaries of the abdomen and pelvis when we order CT scans. If you order a CT scan in the hospital and you order just an abdomen, you will literally just get that portion that is seen here. You will get just the abdominal contents. However, I don't really think that there's any exception to ordering an abdomen and pelvis. They should come together because for the most part, the organs in the abdomen are contiguous with the organs in the pelvis. So get in the habit of always ordering CT scans of the abdomen and pelvis together. They should be one study. Do not rely on your radiologist or the radiology technician or the CT scan technician to add the pelvis because they won't. They're billed differently and they're coded differently. So based on what we see here, the apex of the diaphragm at the tip of the xiphoid process down towards the pubic symphysis describes the abdominal cavity. Here we have the pelvic cavity. So on this transverse image, this is normally what we would see if we were looking at a CT scan with the various spaces defined. So let's take a look and go through each one of these. Of course, here is the rectus muscles, which we've learned. We have the ribs out here, which are easy to identify. But we're interested in what's going on inside the abdomen. So of course, here is the spinal canal. Here is one of the vertebrae. And then here is the lining of what is considered the retroperitoneum down through here. So this is all retroperitoneum that's back here. To identify and start with, of course, we see the left kidney, the right kidney. We see the adrenal gland, and then here's the aorta. Next to the aorta is the inferior vena cava. Moving into the peritoneal cavity, into these various spaces, we can see the liver, and the liver is covered with a very thin, shiny peritoneal lining called the visceral peritoneum. No surprise there. Here's the falciform ligament. It attaches the liver to the undersurface of the anterior abdominal wall. Of course, the stomach, the spleen, and needless to say, we have some of these ligaments, lienorenal ligament or the renal lienal ligament, either way, the gastrosplenic ligament, and of course, we talk about the lesser sac and the greater sac. Here is the gastroduodenal ligament, and contained within it is the bile duct, the hepatic artery, and the portal vein. When we talk about inserting a finger into the lesser sac, this epiploic foramen, also known as the foramen of Winslow, allows us to put a finger here and pinch off the gastroduodenal ligament, which contains most of the blood vessel going into the liver. The portal vein gives 70% of the blood flow into the liver. The hepatic artery is 30% of the blood flow into the liver. We can pinch right here. That's called the Pringle maneuver when we do that and stop the blood flow into the liver. So looking at some of these spaces, of course, we have the greater sac, which is just another name for saying the peritoneal cavity. And then there's the lesser sac, which sits behind the stomach but anterior to the pancreas. This image does not show us the pancreas. So again, we're just looking at this dotted line to point out to us where the retroperitoneal structures are located. So here's the pancreas. It's a retroperitoneal structure. Here's a splenic vein joining into the portal vein. Here's the aorta. And I can't tell exactly from this level, but this vessel here coming off of the aorta is probably the superior mesenteric artery. Next to the aorta, of course, is the inferior vena cava. And then we have the left kidney, which we can see here, liver, and the falciform ligament is located here. Here's the stomach proper with an air bubble in place. And we can see the spleen, and we can even begin to see ligament coming off of the spleen at the hilum. Not yet well seen. But for this talk, where we're going to be talking about the retroperitoneum and the kidneys, we're talking about this area back here that will include both kidneys, the adrenal glands, the aorta, the vena cava, the pancreas, and in this example, portal vein and splenic vein. So let's take a look at the male peritoneal cavity. No surprise here, if we split you down the middle, almost everything that we can see and put our hand in and about is this is the male peritoneal cavity. It's the glad bag, if you remember that analogy. Everything below this, we'll see this later, everything below this, for example, the uterus is considered subperitoneal. The bladder is considered subperitoneal. So in the female, all of this is peritoneal cavity. And you might get confused by, if we open up an abdomen and look in there, you're going to be able to see the uterus, but it's covered with a very thin membrane of visceral peritoneum, which makes it retro, i.e. subperitoneal. So again, if we look at this sagittal section, we can see the liver here and this peritoneal lining, which comes over the liver, and the bare area of the liver, where the apex of the liver is attached to the diaphragm, there is no peritoneal covering up here. If you remember, we care about that because tumors can grow into this space and they can become exceedingly large, and because there's no pain fibers and peritoneum covering that, the patient doesn't realize they have a tumor there until it gets really large. So small ligaments, coronary ligaments. In the retroperitoneum, we have the aorta, and then we have the three unpaired branches that come off of the aorta and the retroperitoneum. We're going to have the celiac axis, which gives blood supply to the foregut, superior mesenteric artery, which gives blood to the midgut. Here's the duodenum. And we don't see it here, but there's an inferior mesenteric artery, which gives blood to the hindgut. So again, the peritoneal cavity is mostly all of this in here, all of this here, here up around the stomach under the liver, and the lesser sac is behind the stomach. So the lesser sac comes down into the fold of the greater omentum, but all of this other stuff here is the greater sac. And then here is uterus, which is considered subperitoneal. Here again is peritoneum going over the uterus, making the uterus a retroperitoneal or subperitoneal structure. So we're going to look here at greater and lesser sacs. This is not a great image to see this on. This is a sagittal section on a CT scan. We can make out the aorta. We can make out the superior mesenteric artery. Pancreas is not well seen. Stomach bubbles. There's bubbles of air here in the colon. Not a good image to show us the greater and lesser sacs. It doesn't show up really well here. So now let's look at some of the peritoneal ligaments. So I mentioned the hepatoduodenal ligament that contains those three structures. That's not minutia, people. You got to memorize what's those three structures in the hepatoduodenal ligament: portal vein, hepatic artery, and the common bile duct. I can put my finger in here and pinch off the hepatoduodenal ligament and stop the blood flow into the liver, because the blood vessels that go to the liver are in the hepatoduodenal ligament. If I stick my finger into the foramen of Winslow, also known as the epiploic foramen, I can pinch those structures, again, called the Pringle maneuver. I can also raise the stomach up if I cut the gastrocolic ligament, or the connection between the stomach and the omentum, gastrocolic ligament here. I can raise that up and put my hand back into the lesser sac. Why is this important on a regular day? It's not, but to surgeons, it's very important to be able to get access to the pancreas. And when we irrigate someone's abdomen, if they have a perforation, we have to make sure that we can clear out all of these spaces of any pus or bacteria. And the abdomen's hard to irrigate, but we have to know where all of these little nook and crannies are located so that we can get to them. So CT scan of our falciform ligament. Remember, this is the ligament that joins the liver to the undersurface of the abdominal wall. Here's the stomach, and the reason it's white is it has oral contrast in it. That could be barium, but it probably is a substance called gastrographin. Barium is a better contrast agent, but we usually give gastrographin. It's an iodine-containing mixture that gives people diarrhea usually after they have the gastrographin. Barium can get stuck, so we don't like to use barium, and if we do, it's dilute barium. So, of course, we have the spleen here. Here is a little bit of adrenal gland. Here's aorta, and here's right lobe of the liver. And this is the surgical right lobe of the liver. This is the left lobe of the liver, and it's divided right here by the falciform ligament. And here is one of the branches of our portal vein. This is telling us basically what the other image was, and that is we have to know where all of these spaces are, all these nook and crannies. And here's why this is clinically important. Let's say somebody has a stomach ulcer, and there's an ulcer in the stomach. It's perforates and it spills stomach contents all over the abdominal cavity, all over the greater sac into the peritoneal cavity. There's pus that will drain down into the right paracolic gutter. We actually call that gutter syndrome. So the patient comes in and they hurt down here in the right lower quadrant because all of the gastric contents and the acid has settled down into this area, even though the perforation was located up here. And you say, well, why is that? Because all the acid contents went down the paracolic gutter into this empty space that's here and settled into the right lower quadrant. So they come in, they have pain in the right lower quadrant. You're thinking appendicitis, and you get in there, and lo and behold, they've had a perforated ulcer. So just looking at some other areas here, we have the right paracolic gutter, the left paracolic gutter, and then we have these areas into the small bowel mesentery. They're calling it the infracolic space. Not so important. Just know that there are lots of cubby holes here, and the important ones that you need to know are the lesser sac, which is up here behind the stomach. Raise the stomach up. Lesser sac is here. You have a right paracolic gutter, a left paracolic gutter, and then down here deep into the pelvis. Those are the ones that you need to know. So these subphrenic spaces, again, not something that's really that testable, except for a couple, and I'll point those out. But again, all we're doing is showing you these empty spaces where pus and fluid and blood can collect. So I open the abdomen. So here is midline. So this is rectus muscle. This is linea alba. I take my knife. I enter the abdomen through here. I stick my hand in here, and there's an empty space over the liver up here. There's an empty space up here, again, over the apex of the liver. And then here is lesser sac, entrance into lesser sac. And here is pancreas. All of this is retroperitoneum, okay, up over in the pancreas this way, like this. Here's our spleen. Here is a splenic gutter is what we call it. And here is a small area between the stomach and the spleen. This turns out to be important because there's these little tiny vessels that are between the spleen and the stomach. They're called the short gastric vessels. And those little guys can be troublesome, and they can bleed like crazy if you end up doing a splenectomy for someone from trauma, or if you end up having to wrap somebody's stomach if they have something called a Nissen fundoplication. That's an operation where we take the stomach and we wrap it around the distal esophagus for people who have bad heartburn. And in order to free up the stomach, we have to cut the short gastric vessels. So if a splenectomy is performed by a surgeon for any reason, trauma, disease, cancer, lymphoma, doesn't matter, we have to clip those short gastric vessels. So again, pancreas, and behind the stomach is the lesser sac in here, just showing us where there are spaces where pus and blood and fluid can be seen and palpated. So this is a really good cross-sectional CT image showing fluid within all of those peritoneal spaces. So here, of course, is the liver. Here is the xiphoid process. So normally we open the abdomen right down the midline. And if in this patient, I would put my hand in and I would see that there's all this fluid over the visible and palpable area of the liver. And as I look over here into the left side of the abdomen, there's fluid here around the spleen. There's fluid in here between the spleen and the stomach. There's air here in the stomach, so the stomach thickness is what you see here. And then there's a little bit of fluid in between the stomach and the liver in this area, which is normally where the lesser sac would be. This is air. We are just catching the base of the lungs here. And they say the bare area of the liver, you can't see that on CT scan, not that well. So the important point when you look at this CT scan is to know that this is abnormal. This fluid shouldn't be there. This fluid shouldn't be there either. Fluid in here shouldn't be there. And this is just normal gastric contents. That's normal with an air bubble that you see in it. So now let's take a look at what we're actually here for, and that's the renal system, the urinary system. So obviously we have two kidneys, and we know that classic anatomy where we have the left renal vein crossing over the abdominal aorta, and then we have the three unpaired structures of the abdominal aorta. So we would have celiac trunk, and it's not shown here, but we'd have the superior mesenteric artery and then the inferior mesenteric artery. Here we have some lumbar arteries coming off. Kidneys, of course, give rise down here into the ureters, which go to the bladder. In a previous talk I gave you on imaging of the urinary system, we spoke about how the water goes over the bridge, and sometimes water goes under the bridge, and all those crazy things that surgeons try to remember where the ureter is located. But this is a pretty good rough diagram of what we're going to delve into. Here we have a sagittal image of the body taken just to the left of the midline. So here we're looking at a kidney that's been sectioned in its sagittal image. We can see the left kidney, of course, the renal cortex here. We can see the major calyce here. The renal pelvis makes up all of this. Renal pyramids, of course. Right here's a pyramid. There's a pyramid. And the posterior abdominal wall with the diaphragm coming up here. Here's lung. Here's the heart. Here is a portion of the liver. This, of course, is stomach coming down to eventually what's going to give us the duodenum. This is small bowel in here. It has a little bit of contrast in it. That's why it's speckled and a little bit white. Here's the colon, the large intestine. It has a little air in it. This is small bowel here too. But most importantly, what we're looking at here with the kidney, so this is going to be the pelvis. Eventually, this is going to go and turn into the ureter. So again, let's look at these. We got pelvis with major calyces. Here's the calyces. Pyramid is here. Pyramid there. Pyramid there. Cortex, and of course, all of this is called the medulla. So this image shows us a coronal midsection view of the kidney. So we have the adrenal gland, which is this triangular shaped structure that sits on top of the kidney, which makes sense. Adrenal. Ad means above, renal means kidney. So here's our kidney. Here's our ureter. The pyramids, which we have here. This is cortex out here. All this is cortex. This is all the medulla in here. And then we look at this perirenal fat, and there is a fascia right here around the kidney that divides the pararenal fat with the perirenal fat. This is called Gerota's fascia, and it's important because it can act to tamponade bleeding if we get a kidney punch, or if we get in a car wreck, or if there's a cancer that tries to move outside of this fascial plane. Gerota's fascia does its best to try to contain blood, tamponade blood for bleeding, and also to prevent tumor spread. But what's important to look at here is to know that even on CT, and we're going to see this in a second, that we can actually appreciate these major and minor calyces. We can see the pyramids. we'll be able to see the adrenal gland and Gerota's fascia too. So MRI of the kidney, and it's showing us again in a coronal section. So here is the left kidney, here's the right kidney, here's the liver, here's the spleen up here. Notice on your MRIs that the resolution isn't quite as good as CT scan. In another 10 years, that will not be the case. Some of the MRs today are absolutely stunning. The images here are showing us what we need to become familiar with. Here is our lumbar vertebrae. Here is our intervertebral disc. We can see a little bit of the adrenal gland here on the right. Not sure if that's adrenal gland up here on the left, but we can see a little triangular shape, which is adrenal. And then if we look at it, we get sort of a blurred image, but we can appreciate the calyces, the medulla, and then of course the cortex out here of the kidney. Again, another view, mostly looking at the same thing, except instead of being an MR, this is a CT scan, and it's really showing us the same thing. So let's look at where we know all of that physiology you learned takes place. It happens in the renal cortex and in the renal medulla. And up here in the cortex, up here, that's where the nephron is located. So here's Bowman's capsule. Here's a little glomerulus out here within the cortex. And again, another little glomerulus with all of our convoluted tubules. Our loop of Henle comes down here. But what's important for you to know is that it's the cortex that houses the glomerulus and houses the afferent blood flow and the efferent blood flow, and down deep into the renal medulla. So here's our columns, and this of course is our pyramids. This is a renal papilla here. So here's our pyramids. But what's important, as I was saying, is that the glomerulus and the afferent blood supply comes into the glomerulus around Bowman's capsule, and then you have efferent glomerulus out here, and the loop of Henle comes down here into the renal medulla. But we don't really care about this. This is for physiology. We're trying to look at this on a CAT scan. So let's see if we can identify all of these on a CT scan. So here is spleen, here's left kidney, here's right kidney. All of this big fat cortex here, medulla, can't make out much more here. Can make out the vertebra, intervertebral disc, the liver. We can start to see a little bit of fascia here, separating the pararenal from the perirenal fascia, but not such a big deal. The idea is just to be able to recognize on this study the kidneys and psoas muscle. Here's psoas muscle. Same thing here. Now we're looking at an excretory phase. We've given the patient intravenous contrast, and the kidneys have begun to collect that contrast. Remember, you can't give IV contrast to a patient if they're in renal failure. So this person obviously does not have kidney failure. The contrast can hurt the kidneys. Here is some absorption and of the contrast, and they're getting ready to pee it out. But what we can see here, there's renal fascia right there, separating perirenal fat from pararenal fat. Some textbooks will point directly to the kidney and tell you that Gerota's fascia is this tiny, adherent, almost thin saran wrap on the kidney itself. And other textbooks show us that it is the fascia here that makes up Gerota's fascia. I don't really care, because once you get into the abdomen and you're back there playing around with Gerota's fascia, it's usually a bad day because you've got a kidney that's bleeding and you need to go explore and look at it. So our calyces can be seen here. The renal pelvis can be seen here. And we can't see yet where the pelvis is going to give us the ureters. Not yet. So now let's look at those pararenal spaces. So right kidney. So this is pararenal fat. Here's pararenal fat. Here is going to be perirenal space. And there is Gerota's fascia. Left kidney, right kidney. The thoracic vertebra or lumbar vertebra, probably lumbar vertebra, aorta, vena cava, small bowel, right here. This is colon. This is the transverse colon. And you can tell because you can see these little haustra in it. And you can see the air bubbles in the colon. This is ascending colon. And this right here is descending colon up near the splenic flexure. So here we have an MRI image, again, a coronal section, showing us the kidneys bilaterally and an emphasis on Gerota's fascia. Here, Gerota's fascia is outlined around the right kidney. This is being the perirenal fat, this being the pararenal fat. Again, not that that is so crazy important. Here we see the stomach, the spleen, we see the left kidney, the right kidney, the hilar structures, not really clearly delineated yet. Psoas muscle, and of course, you can see the intervertebral disc along with the discs themselves. So here is another CT scan image of a cross-section directly through the kidneys. Here we are seeing aorta, inferior vena cava. This is small intestine. This is left kidney, right kidney. Here's the beginning of the ureter, renal pelvis, collecting system of the calyx. And here's renal fascia. Notice they just call it renal fascia. So is it renal fascia or is it Gerota's fascia? Or is Gerota's fascia actually nestled directly onto the kidney? Again, it's not such a big deal. It's not so clinically important. Let's take a look now as we follow through. We can see the ureters are lighting up because they have contrast in them. And adjacent to the ureters, and you'll notice that the ureter sits directly on it, is the psoas muscle. This is a classic relationship that will allow you to find the ureter. Find the psoas muscle, and directly on top of it, usually you'll find the ureter. So here is aorta, here is inferior vena cava, and then we see contrast all within the small intestine. Here is ascending colon, and I'm not sure what this fuzz is here. So if we're going to look at the paired branches coming off of the aorta, of course, we've learned the unpaired branches, celiac trunk, SMA, IMA. The paired branches coming off the aorta, of course, are your gonadal arteries. And then, of course, you have your phrenic arteries coming directly off of the aorta, as well as your renal arteries. So let's take a look here at the right kidney. It has a renal artery coming to it with its segmental branches. And then, of course, the gonadal arteries will come directly off of the aorta. Now, the gonadal veins are a little different. The left gonadal vein comes off the left renal vein and the inferior vena cava on the right. Phrenic artery, blood flow directly to the diaphragm because of the word phrenic. And then, of course, it also gives branches directly to the adrenal gland. So let's take a look here in the anatomy that we've seen a million times. So here's left kidney, right kidney. This is the inferior vena cava and the aorta. And we know that the renal vein, the left renal vein, crosses over the aorta. So here's the left renal vein crossing over the aorta, draining into the inferior vena cava. This has contrast in the collecting system of the left kidney and contrast in the collecting system of the right kidney. This is stomach. Here is descending colon. Of course, this is liver. So I think what we're seeing here is the aorta with the left renal vein and the superior mesenteric artery coming directly over that left renal vein in that classic relationship. And it does look a little pinched here. If this had varicosities with it, we could make an argument that this was nutcracker syndrome. I suspect that this small area that has some contrast in it, there's some whiteness here, is probably a portion of the pancreas, because we know that the superior mesenteric artery and the superior mesenteric vein, which I cannot see here, come out beneath the head of the pancreas. So this has got to be probably a portion of the pancreas, but I'm not 100% sure. So as we move on to look at the blood supply of the renal artery, the vein, and of course the collecting system made up of the major calyces forming the ureter, we notice that the renal artery comes into the hilum of the kidney, and then it branches into segmental arteries. Here's a lower segmental artery, and then here is an upper segmental artery. And once we get into the segmental arteries, then it begins to branch. So here's a middle segmental artery, and it begins to branch into interlobar arteries. So in between the lobes, which look like they're coming up through the columns here. And then as they branch and go around the pyramids, they go from interlobar into interlobular arteries. And then even smaller, of course, are going to be your arcuate arteries. And then the return is the opposite when it comes back to us. But you can't really see any of that on CT scan. Here's an MRI. This is actually an MRA angiogram of the kidneys and the arterial system. So here, of course, we have the celiac trunk, the superior mesenteric artery, inferior mesenteric artery. Again, those are the three unpaired branches off the abdominal aorta. Paired branch, renal arteries. This is the left renal artery, right renal artery. And then it branches out into a segmental artery and a lower segmental artery. Let's take a look at the adrenal glands because they also have a blood supply to them that's related very much to the kidney. The adrenal gland usually has three sources of blood coming to it. One is directly from the aorta. The other comes from phrenic or directly from the diaphragm. And then another will come directly from the renal artery. So we usually have three branches that form a blood supply to the adrenal gland itself. So here's a good example. The middle suprarenal artery coming directly off the aorta. Here's a superior suprarenal artery, and then which has branches that come off the inferior phrenic artery. But look at the shape of our adrenal gland, sort of this pyramid shape. The cortex is out here. The medulla is on the inside. And the cortex of the adrenal gland is responsible for creating corticotropic hormones such as cortisol. And then medulla is responsible for making things like epinephrine. This is a pretty simple diagram. It shows again the classic relationship of the superior mesenteric artery coming over the left renal vein. Here's the left renal vein, the renal artery, and then the branches coming directly to the adrenal gland. So this is not minutia here. One of the hard things that a lot of students find is identifying the adrenal glands, and they can appear as just a sliver or an upside down V or an upside down V, maybe like a letter H. They can be a pyramid or a triangle, or they can be like an upside down check mark. And we'll see as we move on how this actually looks. So let's take a look at the adrenal gland. So here is the right kidney. Here's the left kidney, and right above it is a left adrenal gland, and it's nothing more than just a little wisp of tissue. Here is the right crus of the diaphragm. That is not the adrenal gland, so don't get that messed up, but you can see a little tiny triangular shaped structure here above the right kidney. It's just beginning on this coronal image to show us the right adrenal gland. So here is our classic relationship. The vertebra, we have the aorta, the right crus of the diaphragm, the kidney, inferior vena cava, and between the kidney and the cava, we have the right adrenal gland in this area here. So let's take a look. Here is aorta with probably SMA coming off. Although this is obviously a curlicue from our splenic artery. So this is curlicue like the little pig's tail. This is classic and pathognomonic for the splenic artery. So I suspect this might be celiac trunk here, giving off a splenic artery here. Stomach, descending colon, we have the left kidney. This is the adrenal gland here, the upside down V, sort of maybe even an H. Here we have crus of the diaphragm. Here's the IVC, inferior vena cava, and then we can see this upside down little sliver of tissue here, which is the right adrenal gland, and just beginning to see the right kidney. So again, if we look at the left adrenal gland, we have the classic anatomy. So we have the vertebra, aorta, we have the crus of the diaphragm, left kidney, above the kidney is going to be the adrenal gland. And then here we see the splenic vein that runs on the inferior portion of the pancreas. Remember, all of this is retroperitoneal. All of this on this slide is retroperitoneal. But you're going to see the splenic vein, which is not a curlicue. It doesn't look like that little pig's tail. The splenic vein comes along the inferior portion of the pancreas and will eventually drain into and form the portal vein with the superior mesenteric and the inferior mesenteric veins. So let's take a look at this. So here again, vertebra, this is crus of the diaphragm right here. We have kidney on the left. We have adrenal gland here. This has contrast in it, little curly Q pig's tail, probably the splenic artery. And then the celiac trunk coming off here, giving rise to the hepatic artery. Here we have left lobe of the liver, falciform, right lobe. We have the right kidney here. This is the right adrenal gland in the inferior vena cava here. Perirenal fat. I cannot really appreciate Gerota's fascia anywhere here on this image. So Morison's pouch is that space that sits right at the very lower aspect of the liver, but above the right kidney. Morison's pouch is really a spot where a lot of fluid, pus, bile can collect. So when you're looking at these scans, you want to look at some of these empty pouches. There shouldn't be anything in here. There shouldn't be fluid, acidic fluid, ascites from liver failure. There shouldn't be blood there. There shouldn't be pus there. And we've already covered these different empty spaces in the peritoneal cavity. And also one other thing, note the spelling here. This is a correct spelling. I used to always spell it with 2 R's, but that's just wrong. So here, Morison's pouch here is at the very inferior aspect of the right lobe of the liver, and here's the kidney. So our retroperitoneum comes up here. This is our retroperitoneum. No idea where the pancreas is here. I think this is probably pancreas. Not sure. Gallbladder. And all of this is fluid that shouldn't be there. So this is liver. Here's gallbladder. This is fluid. All of this right here, this should not be there. Okay. And that little bit of fluid in Morison's pouch should not be there either. Of course, this is the fascia of the retroperitoneum. I guess you could call that Gerota's fascia. Not really sure there. Anyways, so we've covered it, the retroperitoneum, the kidney, the adrenal gland, the spaces, and we'll go on and look at more structures of the abdomen itself when we move to the GI system. Thanks for listening.